You can either text in or unmute yourself and answer that question if you would like. I will be asking maybe for some participation as we continue today. So if anyone wants to answer. Okay, so everyone's going to be a little bit quiet today. Okay, so, you know, there can be many different reasons why a suicide is not reported. It can be that maybe somebody overdosed and it wasn't necessarily determined or reported as a suicide versus that, you know, it was just an overdose. But there are different reasons, and that kind of comes down to the coroner and how they rule that. There is an average of one suicide every 11.7 minutes, so that's a lot. When we look at youth under the age of 25, that average is one suicide every hour and 32 minutes. So there are, in 2016, 5,723 young people died from suicide. It is the 10th ranking cause of death and the second ranking cause of death for youth. I also want to point out that 3.4 male deaths by suicide for each female death. And the reason for that is that males tend to use a more lethal means, whereas females will maybe choose to take pills or cut on themselves, and males may use a firearm. Okay, this is the 10 leading causes of death by age group in the United States in 2016, and you can see there the second line, there is ages 10 to 14, 15 to 24, and 25 to 34. Suicide is that second leading cause of death for those age groups. Above that is the unintentional injury. I like to show this because you can see that kind of the rate that we are, and looking at this, I think this kind of depicts a little bit where that stigma comes into play in our region. And if you look on the coast, you will see that they are much lower than we are, with 21.1 with that rate. And I think what it is, it kind of goes back to that stigma, and people on the coast are, you know, they would be okay with saying, hey, I'm going to go grab lunch and then I'm going to go see my therapist. And so they talk about it a little bit more openly, whether, you know, we may not talk about it as openly, and we want that to change. Again, here is the national stats. You'll see that South Dakota is rated 13th. And in 2016, there was 163 deaths by suicide in the state of South Dakota. In 2015, there were 173, and we were ranked number 7th in 2017 or 2015. But people may see that as being a large decrease in suicides, but with the population as small as South Dakota, the number only increases slightly. And in fact, we are seeing actually in many different counties a rise in suicides. So for South Dakota, the elderly is ranked number 38th. Again, in South Dakota, it's the second for youth ages 10 to 19. But, you know, going back to that other slide, you see that that actually does go up to age 39, that it is the second ranking cause. Native American rate for suicide is 1.8 times that of whites, and firearms are the leading method that is used in suicides. So with our national attempt data, there are over 1 million annual attempts in the US each year. And so that translates to an attempt every 28 seconds. Again, that attempt ratio is 3 to 1 for female to male. So females do attempt more often than males do, and males complete suicide more often. There are 25 attempts every year. And if you look at the youth there, you'll see 100 to 200 attempts per one youth suicide, and then the elderly is 4 to 1. And what we know, obviously, about youth is that they are, first thing that comes to mind, they're pretty impulsive. So they may try whatever comes to mind, such as, I'm going to take 10 Tylenol, thinking that may kill them. Obviously that would not. And with the elderly, they would, obviously they have that life experience, as well as, they may research things more, okay? And actually the attempt rates, are also underreported, because you may have those people that may take pills and thinking that they are going to die, and then they wake up the next morning and they may not report that to anyone. Okay, so with the division of American Association for Suicidology, you can look under Action Alliance for Suicide Prevention. We have the Way Forward, that's Pathways to Hope, Recovery, and Wellness with Insights from Lived Experience. And this started in 2014, and it's a public-private partnership with Suicide Attempt Survivors Task Force. And they really want to, convey the voice of suicide attempt survivors. And it's to help serve as that bridge between, working on that conversation about suicide prevention, and between the mental health policymakers and consumer advocates. And so just, again, getting their voice out there, making it okay to talk about mental health. And you can also see there is the suicide loss survivors responding to grief, trauma, and distress after a suicide. And you can go on and look at that with the national guidelines as well. So just some quick suicide survivor data. And again, you guys know that you can, if you have any questions, you can either unmute, feel free to ask questions, or you can type in your questions. So please let me know if anything comes up, or if you have any questions regarding anything.
And Sherry, if you want to ask a question and you want them to be able to talk, I can unmute all on my end.
Oh, okay, perfect.
So I just have you paying attention. So if I'm not, say my name.
Okay, great. It seems odd to not have those people in front of me and talking back and forth. So yes. Okay, so some survivor data. Again, survivors are people who have lost a loved one to suicide. So for each suicide death, there's at least 147 people that are exposed to that suicide. So at least 147 people know about the suicide and have dealt with that suicide. More than 6 people experience that major life disruption in their life. And, as we all know, that can also be more far-reaching than that as well. So if we lose a child in school, that can affect the entire school and the entire community. There is an estimated number of survivors in the US. It's over 5.2 million lost survivors each year. And suicide risk is greater in those survivors, especially if a child has lost a parent to suicide. But we also see that, you know, sometimes, especially if we're looking at schools, there may be that suicide contagion that happens within the schools. And so we'll talk about some of those school resources later on in the presentation. Okay, I do have a video with Kevin Hines. He is a suicide attempt survivor who jumped off the Golden Gate Bridge, and I will show that video here. If I can figure out how to do it, give me a minute. Can everyone hear that okay?
Far too many lives traveling the path to this day. Since 1937, over 2,000 people have died at the Golden Gate Bridge. I feel lucky to be alive every single day. For the thousands that have died off the Golden Gate Bridge, I am of the 1% who have survived. So I was born on drugs and premature. And then I bounced around from home to home. Nobody wanted to keep me because I was sick. And I got lucky. I landed in the home of Patrick and Deborah Hines. I had a great childhood. I thought growing up that everything's going to be great. And then at 17, it all came crashing down. If you can imagine feeling that everyone around you is out to get you, trying to hurt you, and trying to kill you. And you believe that to be the truth. From the extreme paranoia, I exhibited symptoms of mania. From the mania came the hallucinations, both auditory and visual. And so with that and the bipolar disorder, I just was spiraling out of control. I vividly remember writing my suicide note. People don't get it. Like, I thought I was a burden to everyone who loved me. Because that's what my brain told me, because that's how powerful your brain is. I got off the bus. I walked slowly down the walkway of the Golden Gate Bridge. You know, people rode by me, drove by me, walked by me, and a woman approached me. And she said, "Will you take my picture?" She said, "Thanks," and she walked away. It was that moment I just said, nobody cares. Reality was that everybody cared. Just couldn't see it. I ran forward, using my two hands. I catapulted myself into free fall. What I'm about to say is the exact same thing that 19 Golden Gate Bridge jump survivors have also said. The millisecond my hands left the rail, it was an instant regret. And I remember thinking, no one's going to know that I didn't want to die. In 4 seconds, I fell 75 miles an hour, 25 stories, and I hit the water. I was in the most physical pain I had ever experienced. I have ever experienced. The Coast Guard was amazing. He was just so freaked out that I was alive that he just dove in and brought me on board. The guy said, "Do you know how many people we pull out of this water that are already dead?" And I said, "No, and I don't want to know." The guy put his hand on my forehead, said, "Kid, you're a miracle." My father took one step into the hospital room, and I looked up at him and I said, "Dad, I'm sorry." He said, "No, Kevin, I'm sorry." And if you think about it, both of our immediate reactions were guilt. Guilt that didn't belong to either of us. And even though I didn't die, I caused people a great deal of grief and pain. Just the day of my attempt still sits within them today. I asked my father if he still feared my death by suicide. He said, every time the phone goes off, his first inclination is Kevin alive. I had an impact on my dad. After the jump, the road to recovery was pretty long. I had 7 psych ward stays in the next 11 years. I still have all the symptoms I ever had. Mania, depression, psychosis, hallucinations, all that's still there. I just know how to cope with it and I know how to beat it. I built a support network over these years of treatment so that I wouldn't be fighting this alone. So like, it's okay not to be okay. It's not okay not to ask for someone to back you up. To the families who live with the losses of loved ones, they didn't do that to hurt you or destroy your life. They took their lives because they were struggling and in a great deal of emotional and mental pain. Suicide, mental illness, and addiction are the only diseases that we blame the person for perpetually. But people die from suicide just like they die from any other organ diseased. Today, no matter the pain I'm in, no matter the struggles I experience, I do believe that life is the greatest gift we've ever been given. And if you're suffering mentally, don't wait like I did, sitting in denial for so long. Because recovery happens. Living proof.
Okay, so we actually had Kevin Hines come and speak, and he is such a dynamic, powerful voice. He goes around and kind of dedicates his life to getting the message out there, that awareness of mental health and suicide. And if you have, I'm not sure how many of you actually saw him speak, but if you ever get the chance to see him, I would definitely encourage it if you haven't already. So very, very powerful speaker. And I love how he talks about mental health and so that being a brain disease. And I just like the way that he kind of displays and portrays that when he is giving that message, that there is hope and recovery is possible. So, all right. So moving forward, I just want to talk a little bit about Thomas Joiner's interpersonal theory. He says that three things have to be present for someone to attempt suicide. So they need to be capable of suicide, which means not being afraid to die. And so we know that there are people that are at greater risk of suicide. And so those people that maybe have seen trauma in their lives, or that are affected by trauma a lot, who hear about trauma. So Jody, can you unmute people? And I just want to hear from everyone. What would be some of those people that you feel that would be in this category of, who have experienced or firsthand knowledge of trauma that may be at higher risk of suicide?
People struggling with addiction.
Yes. Mm-hmm.
He said in the video, children of people that have also have either successfully completed suicide.
Yes. Yeah. So, those group of people, I want to point out, like law enforcement, correction officers, emergency personnel, firefighters, doctors. They even have kind of lawyers on that list. And so those are people that have seen trauma kind of over and over, and hear about trauma. And so that puts them at that higher risk. So there's also that thwarted belongingness, so that feeling that that they are alone, okay, that there's no one there for them. And then also that perceived burdensome, feeling that they are a burden to their family and friends. Okay. So
I noticed that on the state list, a lot of them are big, wide open spaces like Alaska, Montana, Wyoming.
uh-huh.
Does that lend itself to the loneliness factor?
Oh, definitely. Definitely. Yeah, people in those rural areas not having, being more isolated and not having access to mental health treatment. Yeah, definitely. Thank you for bringing that up. So we know that the risk factors, protective factors, those play a critical role in prevention of suicide for both individuals and communities. So if we decrease those risk factors, that generally does decrease the risk. And then by protecting those, by increasing those protective factors, that will also decrease that risk. So when we look at suicide prevention, we should identify and target specific risk and protective factors for those interventions. So obviously, we know that those different groups of people may be at higher risk, but we're going to obviously focus on them. But we also know that suicide does affect anyone and can affect everyone, right? Okay. So some major risk factors, and of course this list does not include all of those risk factors, but is a prior suicide attempt. So when we look at someone who has attempted suicide in the past, we know that they are not afraid to die because they've already taken attempted suicide in the past. Okay, so that fear factor is gone. Also, when we look at someone who has mood disorders, major depression, bipolar, schizophrenia, looking at all of those put people at higher risk. We do know that people that have died by suicide have 90% of people that have died by suicide have either mood disorder, substance abuse, or both. I know that in the recent CDC report that had come out, it does report in there that there were, I can't remember the exact percentage, but there were a percentage of people that died by suicide that did not have a mental health disorder. And so, looking at that, when we do talk about this, we're looking at the fact that could have been diagnosed with mental health, but maybe they were not diagnosed with a mental health disorder. Okay. We also know that a substance abuse does come into play, and then, of course, access to lethal means. So if someone is, we know that someone is suicidal, we do need to make sure that we do lock up those means. Okay. So then looking at some major protective factors, that includes that effective mental health care, their connectiveness, being a part of a community, whether that be at school, work environment, church community, just that connectedness with even within, the family. Sometimes there's a lot of disconnect in the family. So feeling of, again, that belongingness and connectedness, and then having those problem solving skills, and then contact with caregivers. And this is more so with when we're looking at adolescents. The risk is lowered when they do have a good relationship with one of their caregivers. So we're going to get into some of the history of suicide prevention. So some of the early steps in the mid 1990s, South Dakota local and tribal officials, they took part in a federally sponsored meeting on suicide prevention. The Helpline Center began in 1974 and continues to offer that suicide crisis line in the state of South Dakota, but began in that Sioux Falls area at that time. Community task force that were started in the 1990s. The first community coalition focused on that suicide prevention and was formed in Pierre and in Sioux Falls. The National Strategy for Suicide Prevention that was released in 2001. And then in November of 2002, there was an ad hoc work group that met in Chamberlain to explore the developing of the SAPST. And I don't know, were some of you a part of this? Jody, were you a part of this at all?
No, I was not.
No. Okay. Okay. So I didn't know if we would have some people on the line that were a part of that, but and then in March of 2003, South Dakota legislature passed that Senate congruent resolution number 5, and so that established that suicide prevention as a priority in South Dakota for the South Dakota strategy for that suicide prevention. So it was then recognized at that time. And that kind of kicked us off with suicide prevention in South Dakota. So in early June of 2003, the work group met in Sioux Falls, and some goals were drafted and objectives to form that core state strategy. And the Helpline Center was a part of that and kind of helped to prepare that. In January of 2005, that was presented to the state legislature. So looking at some themes that came up in 2012, and I'm just going to advance this. So when we're looking at the national strategy for suicide prevention, you know, we know that everybody has a role in preventing suicide. You know, it's to foster that positive public dialogue and addressing those needs of those vulnerable people. And it's to, you know, promote that systems of change. So bringing together both public health and behavioral health. And that was really kind of the goals that were set out. And in this slide, you can see there were 4 strategic directions, 13 goals, and 16 objectives when we look at this. And it looks at, you know, reducing that access to lethal means, empowering individuals, families, and communities. Strategic number 2, clinical and community preventative services, treatment and support services, and then of course looking at that surveillance, research and evaluation piece of that. And, you know, really making this, you know, everyone has a role in this in trying to, you know, break through that stigma and, you know, letting everyone know that they do have a voice. You can, I'm not going to show this video right now, but you can definitely go on and look at that video at a later date. So in 2012, there was that updated national strategy for suicide prevention that was released in 9 of 2012, and then that just reflected changes made in the fields, you know, in the past decade, and that update for South Dakota strategy was completed in 2013. And there is that link there, so again, it talks about those goals, objectives, and the action plans. There were 10 goals. Again, so kind of integrating and coordinating that suicide prevention activities across multiple sectors, improvement of the evidence-based communication efforts, increased knowledge of factors that offer protection from suicidal behaviors that promote that wellness and recovery, promoting responsible media reporting of suicide. And, to this day, we still see some of the media reports that can cause harm when reporting on suicides. And so I think that still continues to be a work in progress and a constant with looking at that. And then, of course, promote efforts to reduce that access to lethal means, provide training to community clinical service providers on the prevention of suicide, and then, of course, related behaviors, mental health behaviors, addiction, promote and implement effective clinical and professional practices for assessing and treating those identified as being at risk, provide care and support to individuals affected by suicide deaths and attempts. So that's part of that postvention, making sure that we look at that unique type of grief that someone experiences when losing a loved one to suicide, and then helping those people that have attempted suicide, making sure that they get the mental health care that they need at that time. Increase that usefulness of the surveillance system relevant to suicide prevention. So improving that through the state, tribal, and community capability to collect and analyze all of that data so that we can continue to make improvements. So we also want to promote, evaluate, and then annualize the information, and then, of course, disseminate that out so that everyone has that information that can help in the prevention of suicide. So South Dakota Suicide Crisis Line. Anyone have any questions thus far? Okay. Again, you can just let us know if you do have questions. So in 1999, the Helpline Center did become certified through the American Association of Suicidology. And they expanded not only from Sioux Falls to reach statewide. So anyone who has a 605 area code can call the NSPL number, that 1-800-273-8255, and reaches us at the Helpline Center, and our trained crisis staff answer those calls every single day. And again, those calls are answered. In 2017, we had, again, the 1,831 calls. We look at the level of risk. So again, it can be someone who is just having thoughts of suicide, someone who has a plan for suicide, or someone who is at imminent risk, who may be in the attempt moving forward right there. We have many calls where people, they may have in hand the pills that their means in hand, whether it be pills or guns, and then we need to obviously then take action and make sure that they are safe. And we're going to talk about how we do that here. So promoting the crisis line, this is just one thing that we use to help to promote that crisis line early on. anyone can call in. As we know, people, there are some precipitating events that may lead someone to start thinking about suicide. So anyone can call in using that 1-800 number. So how does our connection centers work? We did call it, it was called the call center. We have recently changed the name to Connection Center because we do more than take calls. We also work with texting as well. So the name did change to Connection Center just recently. So of course, we take those calls from the NSPL. We have our staff are trained crisis staff that can handle those calls. So people who are calling in crisis. At that time, they do a suicide risk assessment with that person. And then there is also, once that assessment is done, they work with them on if they don't, we always do a safety plan. But if that risk is imminent, of course, we will get law enforcement involved if need be. And we're going to talk more specifically about safety plan resources, follow-up, and texting here. So I just want to show you, here's a sample safety plan that we use. So when we work with a caller on a safety plan, we are going to work with them. Okay, so we work with them, and they are the ones, we're going to put their words on this safety plan. So we would ask them, what are some warning signs that you see when a crisis starts to develop? Okay, so that can be, well, I start thinking about hurting myself, or I notice I start getting really depressed. So in their own words, we will put that down as their warning signs. Then we will talk about their internal coping strategies, things that they can do to take their mind off their problems without contacting another person. So what are some of those things that you could do that may help you? And so it may be exercise, it may be reading a book, it may be going to a coffee shop and having, a cup of coffee. And then we also are going to talk about people and that social setting that provide that distraction. So who are people that you can call that have helped you in the past? Who's someone that that you can trust? So we're going to get the name and the phone number so that they have this plan in place. So when a crisis arises, they have this in front of them. And then people who can help. So that may be some of the same people that they have in step 3, but it also may be, I haven't talked to my counselor in a long time. I know that I can always call my counselor. Okay. I know that, I have a really hard time with talking with my mom and dad, but I really do feel like my aunt listens to me and helps and supports me. So making sure that you actually get the name and number there. And then, of course, the professionals or agencies that they can contact during that crisis. So getting those emergency numbers down there. And then, of course, we're always going to have the NSPL number right there that they can call when they are in crisis. Okay. And I don't know if you guys know this, but anyone who has any type of a smartphone, and I'm going to do this, and so don't be alarmed. I'm using my phone to show you something on my phone. So I'm going to talk to Siri here, and I just want you guys to see how this works. So people don't necessarily have to memorize that or know that 1-800 number. So don't be alarmed. This is what I'm gonna say. Hey Siri, I'm feeling suicidal.
It sounds like talking with someone might help. The National Suicide Prevention Lifeline has confidential, one-on-one support, 24 hours a day. Would you like me to call them for you?
No.
Okay.
So when I first learned this, I kind of geeked out and I'm like, oh, wow, that is so cool. So just another way that technology can be used in a positive manner. We all know that sometimes technology can be a detriment to some areas, but it can also be a very powerful positive tool. And then the last step, the step 6, making that environment safe. So we want to make sure that the means is out of the way and, talk with them about, so if they have medication that or pills that they were going to take, we need to make sure that either those pills are given to someone or if they need to take those pills, then that they are locked up and someone helps them with that. Or if they have access to lethal means, we need to then take those steps to make sure that they do not have that available to them in their environment. So making sure that that environment is safe. Okay, any questions on the safety plan? Okay. All right, so when someone calls into the NSPL number, we always do a follow-up call with them. And we will, depending on whether it's level 1, 2, or 3, it is always offered within 24 hours. Sometimes we call in 2 hours, sometimes we call in 4 hours, depending on the need of the caller and their level. So we do offer that follow-up call, and sometimes we call them more than once. We may call them within 24 hours and then continue to check up on them and reassess their crisis level. We will go over their safety plans, and sometimes we even add to their safety plan because maybe at that time of that initial call, they were not thinking clearly. And so we may add to that safety plan or make some changes to that safety plan accordingly. And then we also make sure that we are connecting them to resources. So maybe they didn't have a counselor and have agreed to go to counseling. So then we would make sure that they have those resources and that support system available to them. This is just, in those follow-up calls, what was helpful to you about those follow-up calls, just some information that people have shared with us over the years. It reminded me of my choice. Over the last couple of days after I called the call center, I was still considering the idea of killing myself, and the calls really reinforced that I've chosen not to. She was telling me that I have a lot of potential and I can be whatever I wanted, and that helped out. I'm used to people putting me down, and she didn't. She gave me some ideas on how to deal with my loneliness that caused my depression. So just different ways that we have helped callers. Again, this is just more feedback from follow-up callers. I'm not going to read that to you. I'll give you a moment if you want to take a look at that. Okay, so as we talked about before, we also offer crisis texting to high schools, and we are currently in 46 high schools, and that is called Text for Help. And we will go into those high schools and talk with the students about the Text for Help program. So letting them know that they can text in, it's confidential. We don't report what they say back to the school. Of course, if there is imminent risk that we need to get someone involved, of course, we do that. But what we do report back to the school is the number of people that have text in. So showing how often students at the school use that Text for Help. And a lot of kids do, because they know that it's confidential. We have materials that we do give out to the students when we go into the schools and talk about the Text for Help program. We go over different ways to use the Text for Help program. So they can call in for or text in for themselves. They can text in if they're having family problems, depression, if they're worried about a friend. So we do get a lot of texters that are calling in and maybe worried about a friend or a loved one. There's also a lot of relationship issues and of course suicide issues when they do text in. We even occasionally get people that text in and ask about, how do you do this math problem? And of course, I would be of no help to them when it comes to math. There's a reason I'm in this field instead of being a mathematician. So, all right. So some 2017 texting data. Some of those top issues that were identified when people text in: suicide, relationship conflicts, loneliness and support. And, we oftentimes do get people that text in or call in and they're just lonely. They don't have anyone to talk to or anyone to support them. And we are here to be that support to them. Academic struggles and pressure, we talk with them about those issues, not doing the math problems, but talking about those struggles. And then we do oftentimes then refer them back to the school, to that school counselor, because they have those resources right there in that school. And so a lot of times that's our first step, is getting them then reconnected with the school and the counselor and those resources. And then also they talk about emotional distress. So over 7,000 students were educated in the texting program in 2017. Like I said, there's 46 schools that are on board in South Dakota. And the average text time is 90 minutes. So, and there were over 304 text conversations. And a lot of the questions, some of the questions that students will ask is if we're sitting here on our phones, texting back. And we do not use our phones. We have a computer system that we use to text back and forth with them. And we let them know that those, just like our calls are answered, the texts are also answered immediately as well. But the conversation can go on for an average of 90 minutes because we may not get that response back right away from that texter. Maybe they are in class and then they text back a little bit later. Okay. Any questions thus far? Okay. So we know that this encourages and improves access to students to reach out for help. The level of crisis in teens are reduced after texting. And again, we do, just like when someone calls into the NSPL number, we do offer that follow-up text support to them as well. So teens indicate finding the service helpful and beneficial to them. And this is not just offered during the school year. This is year round that this crisis texting program is going on. Ultimately, we make it easier for teens to gain access to those effective services. And, you know, we focus on helping them to cope with suicidal thoughts, feelings, and we can save a life. So, whoops, sorry. Our texting did then expand into colleges, which we do call our Text for Hope program. And that was through the SAPST grant that we received through the state and with DSS, and that expanded into the colleges. So we have Augustana, USF, SDSU, Black Hills State, and Northern State University. And so we go into the colleges as well, and same as our Text for Help, it's the same concept with Text for Hope. And I'll talk about a little bit more about Text for Hope here in a minute. So just to let you know about this 5-year SAMHSA grant, it started in 2014 and it runs through September 2019 through Department of Social Services. So some specific grant activities. We provide structure. So what we call our follow-up program with youth through inpatient behavioral health or emergency department. So if someone goes into a Vera behavioral health with suicide ideation, they will then offer this follow-up program to them. We will reach out to them within 24 hours of them leaving the hospital setting. And so what we do know is that when someone leaves a behavioral health setting, their risk for suicide does go up. And so this follow-up program has helped to reduce suicide, offer that support to them. So we will make that initial call within 24 hours of them leaving the hospital. We will then follow up with them weekly for up to a month. And then we do a 3-month call and a 6-month call. Now, if that person needs more support, we will also, continue that support with them. But when we talk with them, we go over their safety plan with them. We do a suicide risk assessment. During each call, we do these things. We talk with them about, have you gone to your counseling appointments? How are your medications going? Any changes that have come up. And if we need to intervene, we also intervene at that point. So we also will talk with, family members, especially if it is an adolescent. So ages 10 up to 24 is where these services are offered. Okay, and also through this grant, we do train staff in K through 12 settings, and that frontline staff at those universities, community settings as well. We also have making educators partner in youth suicide, and with this link, those teachers can actually go online and do an online suicide prevention course. We also do go into the schools, into the colleges, and do those suicide prevention trainings as well. we work with our suicide prevention coalitions in training, referral protocols, and working with those at risk or any questions that do come up. And there has been that statewide advisory group that has been developed. And through that, there were subcommittees, youth council, and awareness campaigns, which I want to show you here. So through that, some of these, here are two examples of things that came out of the awareness campaign. And maybe some of you have already seen these posters or materials, but we have the Native American Reach for Life. We have posters, we have cards, we have those pull string bags, and let's see, what else do we have? With the Native American, we have the youth warning sign cards as well. And so these materials are disseminated out through South Dakota. A lot of reservations like these posters and information. So if you can go on the website there and order these, they are free of charge to anyone who wants any of these materials. And then the other one is for the LGBTQ community and safe space. So letting everyone know that, you know, calling the 1-800 number, NSPL number, that is a safe place for them to talk about their issues and struggles that they may be having. Okay, so we have our, obviously when we're looking at prevention programs, we want to make sure that we have evidence-based information that we are using. So practicing evidence-based prevention means using the best available research and data throughout the process of planning and implementing your suicide prevention efforts. And there is a former list of the best practices listing, which was through SAMHSA and the National Registry for Evidence-Based Programs. But that actual list is being discontinued, but it is still available on SPRC website there, but they are moving towards promising prevention practices. So they are moving towards just kind of a different way of looking at that and educating through programs and practices. So with this, they are looking at making decisions based upon available specific evidence, using that data and information systems systematically. You then want to apply program planning framework, engage the community, conduct that sound evaluation, and then again disseminate what we've learned out into the community by giving those prevention trainings. So some of our suicide prevention trainings in South Dakota, there is the QPR, and that's question, persuade, refer trainings, and that's been offered in the state since 1998. Throughout the state, there's many people that are trained in doing QPR and QPRT, and actually all of these trainings. But the QPR is it can be anywhere from 1 to 2 hours, depending on if you do role plays and a lot of interaction with that QPR training. The QPRT training is an 8-hour training, and that is for professionals who work with people who are suicidal. So suicide assessment and that management training. Our assist training is a 2-day training, and it's aimed at developing that suicide first aid. And the way that I like to look at it is when someone, if you're trained on doing CPR, and let's say somebody collapses and you have to start CPR, so you are helping that person until professional help can arrive. So you are assisting that person. And so with assist, you understand kind of your attitudes about suicide. You provide that guidance and suicide first aid to that person at risk. You identify those key elements of effective suicide safety plan and the action required to implement those. So it's really an engaging 2-day training. Very good training. If you haven't been through assist, I would highly recommend that. And then also there is Safe Talk, which is also through Living Works, and that is for people ages 15 and older, and that's a half-day training, kind of just to alert those people to those dangers of suicide. We also have safety planning and means restrictions. So safety planning, you got a mini version of that when I kind of showed you that safety plan and went through some of that. And then means restriction just talks about, how do you keep a home safe? How do you restrict those means and different methods of going through that? So the safety planning, means restriction are both about an hour long, and maybe you have come to some of those trainings. We oftentimes do like a brown bag lunch training when we do safety plans and means restriction. And then we have mental health first aid and youth mental health first aid. This is both 8-hour trainings. Mental health first aid is geared towards people working with adults, and then the youth is with people working with youth. So they work on identifying, understanding, and again, responding to mental illness, addiction, and suicide. And we'll get to this in a minute, but trainings that we are offered in South Dakota are posted on the South Dakota Suicide Prevention website, and I'll get to that website here in a minute. Okay, is everybody still awake or anybody asleep there? Okay, I just wanted to check in because I can't see your faces. So, all right, so just a little bit about suicide survivor services. Survivor support groups have been offered in the state for over 25 years. The Helpline Center has survivor groups, and there are also survivor groups throughout the state as well. Helpline Center began sending out survivor packets across the state in the early 2000s. We do send out a packet to any survivor who is in need of one. The packets are made up of information regarding that unique type of grief that someone experiences when losing that loved one to suicide. And we will get those out to them at any time. The first statewide Survivors of Suicide Conference was held in Chamberlain in September of 2005, and then there was another one in April of 2016. We also have our LOST program, which is Local Outreach to Suicide Survivors. The first LOST team was introduced in Sioux Falls in 2004, and then Rapid City also added a team in 2005. So the loss team is, we will get a call from law enforcement or coroner when there is a recent suicide. And law enforcement will inform family, friends, that the loss team is available to them. So sometimes we will get called and we will go on scene to help to support that family and comfort that family at that time of the loss. Sometimes families do not want someone there at that time, and so they may say, you know, no, have them call me in a couple of days. And so either way that they want that support, we will offer it to them. So it may be that we follow up with them the next day or in a couple of days and get them information that they need, and provide them with that support. We also do follow-up supportive calls to survivors of suicide. We also have provide support to businesses, schools, other organizations. So if there is a business who has lost an employee to suicide, and it has affected many people within that business, we will go in and do a support group with them and help them to process that loss. As well as we will go into schools and other organizations as well. It is very common that we do get calls from survivors on our crisis line. We do have what we call our lending library. We have lots of different resources here, children's grief books and resources for children, teens, that we also give out for those type of resources. We do also offer our quarterly survivor newsletter, and anyone can sign up for that. And that is filled full of supportive educational information, upcoming events for survivors, just important, relevant information for survivors to kind of help them to move along in their grieving process. In November is National Suicide Survivors Day. We oftentimes do a Survivors Day event. Last year we did a candlelight vigil and had a survivor speak at this event. It was a very nice day, and you know, honoring those that have that people have lost to suicide. We also have our Step Forward to Prevent Suicide walks in Sioux Falls. It is in June. We've had our walk for this year. Brookings is typically at SDSU in April, and then the Yankton walk is coming up here on August 4th in Yankton. So we also have our school resources, and I'm going to go over a couple different school resources that we give out, but it can also be accessed through the South Dakota Suicide Prevention website. So there's the Preventing Suicide, a toolkit for high schools. This is a toolkit that helps people with screening tools, looking at those risk factors and warning signs. Of course, there's that research-based guidelines, and it's important for schools to identify those students that are at risk of suicide. And then within those guidelines, there's those protocols to responding to that suicide death. There's educational programs to engage youth in that prevention, suicide prevention. And then, of course, it's always important to get parents and family members involved. So there is a parent education section that provides families with resources and materials. And then there is also a toolkit for schools for after a suicide. So looking at how do you respond to a crisis? How do you respond as a school? How do you respond as a community? How do you help those students to cope with the loss of their friend, of their fellow student? A lot of times schools will do a memorial for the loss of someone who has died by suicide. There's the social media, that suicide contagion, which we talked about a little bit about earlier. So I think in schools that is also kind of a fear of how do I make sure that that doesn't happen, that suicide contagion. And then a lot of times school will bring in that outside help. So they may already have those connections with different counselors, mental health resources within their area. So we talk about how you partner with these people, and making sure that all of these steps are in place before an actual suicide happens within the school, so that they know how to respond to a crisis. And actually, I did a training when it comes to school protocols earlier, and this year, was it April, May? When was that, Dodie? I can't remember off the top of my head, but it was earlier this year, and we may look at doing another training coming up this fall too.
Yeah, I think it was in April.
Yeah. So other school components, some essential pieces to that suicide prevention within schools. So the schools need to promote that emotional well-being and connectedness within the for those students. So remember that, that's one of those protective factors, a student feeling connected to the school and students and teachers. And then identifying those students who may be at risk and getting them the help that they need. And then, of course, that crisis response plan that I talked about, making sure that plan is in place and everyone knows the role of that crisis response. Staff, faculty training on suicide prevention would be a part of that response plan. So making sure that everyone, from the janitor to the principal, is trained in suicide prevention. Excuse me. So I was talking about, here's the website, South Dakota Suicide Prevention website. It was launched in May of 2005. And then reintroduced after a major revision in 2012, and added some key pieces, including that calendar of events. And so here is what one piece of the homepage of what it looks like today. So you see that the logo has been changed here up in the left-hand corner. They've added different, the toolkits were added recently to the website as well. So there are different toolkits that are there, and we'll go over kind of what some of the specifics are that are added. So some of the main headings are about suicide. So just facts and data regarding suicide, getting the help that you need, looking at different types of professionals that are mental health professionals that are available in the field, all of the coalitions, and that page is there where you can reach out to different coalitions, events, the recent events that are coming up throughout the state of South Dakota That's where trainings are also placed. Any trainings that may be coming up in your area, you can go on this site and see what are some current trainings. And then we get into specific populations, we go over some of those specific populations here in the next slide. And then survivors. There is a section for survivors, and then those toolkits as well. So some of the specific populations that are on this website, there's the teens, American Indian, college students, LGBTQ, seniors, parents, veterans, and the workplace. And so there's a wealth of information. I would encourage you to go onto the website if you haven't already and look at all of the information that is located there. This is just another kind of snapshot of under the teen section and some information there if you go on the website. So awareness and outreach, these are just a couple different pamphlets that are available to people, a guide for taking care of yourself after your treatment in the ER, family and medical providers, and then supporting survivors of a suicide loss. And we also reach out to, funeral directors when it comes to survivor and suicide loss. There's also a toolkit for primary care practices, and actually we do go in and speak with primary care regarding suicide, because a lot of times what happens is people will visit their primary care doctor because it's a lot easier for someone to talk about physical pain versus emotional pain. So they may present to their doctor with achiness all over and either sleeping too much or not sleeping enough. And oftentimes 85% of antidepressants are prescribed through the primary care doctor. And so they have that first line of maybe seeing some of the patients that are suicidal. And so we go in and we talk with primary care clinics and talk about, here are some of the steps with working with clients who are suicidal, looking at those warning signs, and then getting them the help that they need, making sure that I think a lot of primary cares are connected with mental health resources, and then just making sure that those are in place and implemented within their practices. And this is just some information that we go over with them, and information that is available to primary care. So, assessing that suicide ideation, screening, assessing suicide intent, and then that 5-step evaluation, which, includes, of course, we need to make sure that, everything is documented. Like what I've been told, and I'm sure what many of you have been told, if it's not documented, it didn't happen. So also looking at, excuse me, how they can plan against any type of lawsuits and working with those clients as well. Okay, so here are just a list of some national resources. Also, if anyone were to call the Helpline Center, we also have a large list of national resources. Or you can simply go on to the Helpline Center website and get those resources that you need that are available right there on the website, also without calling in as well. And any questions? No questions? Okay. Well, thank you all very much. There's my contact information. If you do think about a question later on, you feel free to call me or email me, or you can call 211 and ask for me. Yeah. Well, thank you. Dodie, do you have anything?
No, I had just said I unmuted everyone so they could ask questions. Realized that I said it. So anyway, thanks so much, Sherry. We will do this again next week with Bonnie Ackerman from Prevention Resource Center doing social. So thanks for joining, everyone.
All right. Thank you, everyone.
Thank you.
It's Thursday. Psych meds. No psych meds evaluation. That'll change my mind.